to Alan for organizing, and Les and Avinash, and also thank you, Paul, for taking the time to come and talk to us about LI-RADS. So I think this is one of the many series that hopefully we'll embark on in terms of joint intra-divisional MR conferences. And as we are sort of embarking on the journey for implementing LI-RADS at MGH, I think this is the perfect time. And Paul, if anyone gives an excellent overview on this topic. So it's all yours, Paul. Thank you again.
Thank you. Well, it's great to be here. We'll just dive right in. We're going to talk about HCC and LI-RADS. Just quick background. Of course, HCC is probably the sixth most common cancer worldwide and ranks number 2 in terms of cancer mortality worldwide. It's not as common in the West, in the Western world and in the United States, but it's still a major problem. And over the last several decades, the incidence of HCC tripled in the United States, for example. A lot of that was driven by the hepatitis C epidemic. Now, as we have cures for hepatitis C that are pretty consistently effective, the driver for HCC is more and more becoming either alcoholic liver disease or metabolic syndrome, diabetes, non-alcoholic fatty liver disease. The mortality rate for HCC is close to the incidence rate, so it's a pretty lethal malignancy, but survival rates have in the United States doubled over the last couple decades, and a lot of that has to do with effective screening, catching the disease when it's early, and affording the patient some effective treatments. So let's just start off with a case. Here we have a 59-year-old man with chronic hepatitis C and cirrhosis. You can see that there's a mildly T2 hyperintense mass in segment 4. It's larger than 2 centimeters, minimally hyperintense on pre-contrast, and then definitely has arterial phase hyperenhancement, meaning that it enhances more than background liver. And it has definite washout. It de-enhances more than background liver with a persistent enhancing capsule. So if you've been in the reading room and used LI-RADS or OPTN, you would call this a LI-RADS 5, OPTN 5B. And what happens next? So unlike almost every other malignancy that we deal with, we may make a management decision based on this imaging finding, set of findings, rather than proceeding to biopsy. So that brings us to why we have LI-RADS. Why do we make an imaging diagnosis and assessment of HCC probability rather than just going straight to biopsy? And so LI-RADS stands for Liver Imaging Reporting and Data System. It was developed by the ACR about 10 years ago. It has undergone several updates, and it is essentially what it is a set of imaging criteria and definitions and terminology that are used to assess the probability of HCC in a given imaging finding in the liver in patients who are considered high risk for HCC. So it was developed for several reasons, and the reason we rely on an imaging diagnosis as heavily as we do stems from, number one, when we used to routinely use biopsy for the initial diagnosis, there was a not insignificant, maybe 10% rate of non-diagnostic biopsies. Part of this had to do with some difficulty distinguishing well-differentiated HCC from normal liver background or benign hepatic proliferations. This is less of a problem today, but historically was an issue. The second thing is that because it's a hypervascular tumor, we did have a little bit higher bleeding risk and complication rates with HCC. 2 or 3% with significant bleeds. And more importantly, there was a definite measurable rate of tumor tract seeding or even seeding into the peritoneum that was reported in up to 5% of cases after liver biopsy of HCC. And as you can imagine, for patients that had a potentially surgically curative situation, that could compromise their outcome. So that was a big factor. And then the other issue is that until very recently, there was nothing about the histologic characterization of HCC or molecular characterization that had any impact on treatment whatsoever. In other words, if you had a well-differentiated HCC or a poorly differentiated HCC, your treatment was based on stage and not based on the histology. And of course, that is now starting to change. But these are all reasons why an imaging diagnosis was of interest. And also, it was, of course, noted that we were often quite accurate in making an HCC diagnosis with imaging. So is it a staging system? No. The TNM is a staging system for HCC. We often use the clinical BCLC, which is Barcelona Clinic Liver Cancer Staging System. The Barcelona staging system kind of links the stage with the clinical performance status and with the clinical management strategy that's appropriate. So LI-RADS is simply a way to assign probability of HCC. Recently, the American Association for the Study of Liver Diseases adopted the LI-RADS criteria as its imaging criteria for HCC as well. And we'll talk about the relationship to OPTN later. So let's look at another case. So here is a patient with a very sharply demarcated liver mass, very hyperintense on T2. It has our peripheral nodular enhancement that progressively moves centripetally. And then because this is gadoxetate disodium or Eovist, it does not retain the contrast on hepatobiliary phase. So this is classic hemangioma. And so this would be an LR1 lesion by LI-RADS. So I've shown you now two masses on opposite spectrums of the LI-RADS scale, LR1 with a 0% probability of HCC versus LR5 that has about a 95% probability of HCC based on a recent meta-analysis. LR2 probably falls under 10% risk of HCC. LR3, roughly a third, turn out to be HCC. LR4, maybe 2/3, turn out to be HCC, and LR5, again, 95%. We also can assign a tumor in vein classification. About half of these turn out to be HCC at least. And then we have LRM, which is almost always malignant, but about a third of them are actually HCC because they don't have the classic imaging features of HCC. So one of the things that you'll notice right away is that for LR5, what we're really striving for is high specificity in a diagnosis. So here's just another example of LR1, benign simple cysts that we can call definitively benign. So the LI-RADS categories essentially assign probabilities of HCC. And for LR5, we only use what's called major features. There are 5 major features that we use in LI-RADS to assign a high probability LR5 for HCC. And as you use LI-RADS, this is where you're going to focus really almost all of your attention at the readout station. And what this table, I'll take you through this table. The table shows you the 5 major features that we use. And you'll notice that, first of all, we only assign LI-RADS scores of 3 to 5 using this table. If it's a definitely benign or like probably benign LR1 or 2, we're not going to use the table. Similarly, if it's LRM, we're not going to use the table. So across the top, you can see that the most important major feature is arterial phase hyperenhancement, and specifically non-rim arterial phase hyperenhancement. And the reason they say non-rim is that a thin rim-like arterial phase hyperenhancement is a feature of cholangiocarcinoma and not specific to HCC. And the second major feature is the size of the observation. So is it less than 10 millimeters? Is it 10 to 19 millimeters? Or is it at least 2 centimeters or larger? And then on the left side, you can see the other three major features listed. One is an enhancing capsule. This is a peripheral rim of enhancement that persists into the venous or later phases, and non-peripheral washout. Again, notice they say non-peripheral because peripheral rim washout is something we'll see with cholangio, and it's not specific for HCC, so it has to be non-peripheral washout. And then threshold growth is the fifth major feature. So using this table, you just start off, is there arterial phase hyperenhancement? And that gets you into the right three columns. And then you stratify by size, and that gets you into a specific column. And then you decide whether or not there are additional major features to assign the LI-RADS classification. Notice that you cannot have LI-RADS 5 for lesions less than 10 millimeters. And similarly, if there is no arterial phase hyperenhancement, you cannot assign a LI-RADS 5. That's sort of the sine qua non for the LI-RADS 5 classification. So let's look at another case. So here's a patient with cardiac cirrhosis. There's an arterial phase hyperenhancing mass that's larger than 2 centimeters. It has washout. And so what would you classify this as? So if you go to the LI-RADS table, we have arterial phase hyperenhancement. It's larger than 2 centimeters, and it has washout. So would this be a LI-RADS 5? Well, the answer is that we wouldn't use LI-RADS because it's cardiac cirrhosis, and that is not considered high risk for HCC. So instead, we biopsied this, and of course, it turned out to be a benign hepatocellular proliferation, possibly FNH. And the thing is that it's not that you don't have a slightly increased risk of HCC in a patient with cardiac cirrhosis. It's just that the risk is probably not high enough that LI-RADS can be highly specific. And we've seen a number of these cases that turned out not to be HCC. So when you look at what LI-RADS considers high risk for HCC, you have to have either cirrhosis or chronic hepatitis B, which means you've had hepatitis B for at least 6 months, or a current or prior diagnosis of HCC, because then obviously you're at increased risk. But there are some exceptions. So, for example, if you're under 18 years of age, LI-RADS is not validated. If you have cirrhosis due to congenital hepatic fibrosis or any vascular etiology, that includes congenital heart disease with chronic CHF or Budd-Chiari and so on. All of these vascular etiologies, they may carry an increased risk of HCC, but it's not high enough to make LI-RADS accurate. So this is the patient population that we're going to apply LI-RADS to. Here's another case, a large T2 hyperintense mass, clearly drops on out-of-phase imaging, so it has lipid content. It has arterial phase hyperenhancement and a capsule. So if this were a cirrhotic or chronic hep B patient, this would be LI-RADS 5, but there is no cirrhosis. This was a young woman with a history of birth control pill use, and this wasn't a benign liver adenoma. And so LI-RADS is not applicable. Now, HCC without cirrhosis is a problem, and about 10 to 20% of the HCC tumors that we see occur in patients without cirrhosis. A lot of these are in patients with either chronic hepatitis B or non-alcoholic fatty liver disease or metabolic syndrome. And notice that chronic hepatitis C alone is not considered a high risk for HCC. It's not until you have chronic hep C plus cirrhosis that you are considered high risk for HCC. Now, one of the reasons this whole issue of presence or absence of cirrhosis is important is because the treatment options differ. So patients with advanced cirrhosis, and especially with portal hypertension, are generally considered very high risk for surgical resection, and they do not get surgical resections as a general rule. They may get transplant, but not surgical resections of their HCC. So for those patients, local therapies other than surgery or transplant would be the options. LI-RADS does specify the modalities and the technical details of how you do your multiphasic CT or MRI. There are separate guidelines for contrast ultrasound, which are great for patients that cannot get contrast enhanced CT or MRI for some reason, but I'm not going to discuss the ultrasound LI-RADS any further at this point. Notice that LI-RADS does allow for hepatobiliary contrast agents and provides some guidance on the use of hepatobiliary contrast. Remember, never assign a LI-RADS score to a path-proven malignancy or mass, because the whole purpose of LI-RADS is to assign a probability of HCC, and that's irrelevant if we have a path diagnosis. So these are the categories that we can assign using LI-RADS for untreated observations. And notice that one of them is called LRNC, not categorizable. And it's just important to understand that doesn't mean that it's an indeterminate or intermediate probability of HCC. It means that there's a technical problem with the scan. Either we're missing the arterial phase, or there's motion artifact, or there's some reason that we can't use the imaging to effectively apply LI-RADS. And so in this case, you'll just make a recommendation for alternative imaging or some other strategy. And then, of course, we have the LR1 through 5 for assigning probability, the LRM for malignancies that do not suggest HCC, and tumor and vein that we'll talk about. Now, you may have heard of a MELD score. So for patients who are being considered for liver transplantation, the model for end-stage liver disease, or MELD, is a score that is intended to give a probability of dying from liver disease within 3 months. It's not perfect, but it's what is used to make a clinical estimate of probability of death within 3 months. And so this is used to prioritize patients for liver transplantation. And the most common way to get a score is what's called a calculated MELD score, which maxes out at 40. And the formula uses the serum creatinine, bilirubin, INR, and sometimes sodium levels to determine what the MELD score, the calculated MELD score is. Now, there's another way to get MELD points, and that is if you qualify for an exception. And one of those exceptions is HCC, or hepatocellular carcinoma. Now, the way the MELD exception points for HCC are assigned was recently changed a couple of years ago. And now for if you qualify, you get, for your initial MELD score and first extension, you get a score of 6. And then for the second extension or greater, it's capped at 3 less than the median MELD at transplant for your geographical area. So in other words, they look at what the mean or median MELD score is for patients who actually get a transplant in your geographic area and subtract 3 from that. And for HCC exceptions, it's capped at 3 at that value. And now your prioritization does increase by time on the waiting list. And of course, the MELD exception points are largely based on imaging criteria, but not exclusively. So the implications of this are, one is that the prioritization of transplantation based on HCC was somewhat de-emphasized by this new method of calculating MELD exception points recently. And the reason that happened was that when they looked at 2015, almost 20% of liver transplants went to patients with HCC. And the feeling was that that might be disadvantaging patients with other indications for liver transplantation. So what is stemming from that is that the management of HCC with local therapies or surgical resection is potentially assuming some greater importance in this patient population. At least patients are waiting longer on the transplant list to get a transplant. And so in some cases, if the patients, number one, don't want to have a transplant, then they go to local therapies. Number two, if there's concern about waiting that long, local therapies can be used alternatively, or as a bridge, of course, to transplantation. And in all of these cases, imaging is critical to management. So it's useful to kind of compare LI-RADS to OPTN. And now, the OPTN stands for Organ Procurement Transplantation Network. And so this is the organization that essentially establishes the rules and guidelines for transplantation throughout the country. And they have their imaging criteria that they have required for getting exception points for HCC. And LI-RADS now does a very similar thing. And so how do they compare? Well, I think, first of all, LI-RADS is a more comprehensive analysis, and it really stratifies the risk of HCC in all observations in the liver, not just the ones that are highest risk for HCC. And so it can be helpful in making management therapeutic considerations, even in all cases short of liver transplantation. Another thing about LI-RADS is that there is really a large body of publications and growing list of publications that are studying and analyzing LI-RADS. So I think one of the advantages to LI-RADS is that there's going to be a lot of data behind it. There already is, and there's going to be more. So with OPTN, this has been what was required, of course, by transplant centers to classify lesions and establish exception points for HCC. It didn't specify anything about hepatobiliary contrast, although it certainly allowed for it. It just didn't comment on it. And interestingly, with OPTN, they required cirrhosis to apply their imaging criteria, but they didn't specify what type of cirrhosis. So interestingly, you could have patients with cardiac cirrhosis who might get exception points for HCC if they had an OPTN 5B lesion, even though that might turn out to be benign. But in any case, the OPTN, the goal was just to have a high specificity for HCC in the context of the transplant population. So, you know, at MGH, of course, OPTN has been used and is being used. I spoke with Leanne Daggerford, who's one of the transplant surgeons, and UNOS and OPTN are now, they're okay with using LI-RADS as the method of assigning probability of HCC. And so my understanding is that that's being discussed now as a transition at MGH for doing the reads on this patient population. So another case, an alcoholic with cirrhosis, and you can see on pre-contrast, it's really hard to see the lesion. Maybe it's subtly T1 hypointense. It certainly has arterial phase hyperenhancement. It does not show washout or capsule appearance. This is clearly a cirrhotic liver. So we have a lesion that's large enough. It's 2.2 centimeters. It has arterial phase hyperenhancement. So this would at least be an LR4. We cannot use ancillary features to upgrade to an LR5. You know, there is restricted diffusion, but we can't upgrade to an LR5 with that. But fortunately, there was a prior study from 3 months earlier, at which time the observation measured 14 millimeters. So that was a greater than 50% increase in diameter within 6 months, which is the rule for threshold growth. And so that's another major feature. So now this becomes an LR5 lesion and would qualify for exception points. Now, one thing to know about OPTN is that, let's say we did not have threshold growth. So if we only had arterial phase hyperenhancement in a mass that's at least 2 centimeters in diameter, we could actually biopsy this mass to establish the diagnosis of HCC and generate MELD exception points. So that's one situation where we can use biopsy to establish the diagnosis and still generate MELD points. The definition for threshold growth, again, is at least a 50% diameter increase within 6 months. And this is now congruent between OPTN and LI-RADS, so there's no discrepancy there. Of course, any threshold growth increases the likelihood of malignancy in general, and certainly for HCC. Now, I mentioned ancillary features. Here's the list in LI-RADS. There's some that favor malignancy in general, some that favor HCC in particular, and some that favor benignity. I'm not going to go through these, but it's useful to go through these because it's just from an imaging point of view, understanding these is helpful in our day-to-day reading room assessments of observations. Notice that if we decide to apply ancillary features, and it is optional, you cannot use them to upgrade from an LR4 to an LR5. So LR5 assignments are purely based on major features, and you cannot use ancillary features. If you use ancillary features to upgrade or downgrade, you can only upgrade or downgrade one category, no matter how many features you see ancillary features. And also, if you have opposing features, it doesn't matter whether you have 5 favoring malignancy, 1 favoring benignity, they just cancel each other out. Okay, so here's a patient with a 5.1 centimeter mass. There's a history of hep C and cirrhosis, also alcohol related, very high AFP. So the pretest probability with an AFP this high in a cirrhotic is extremely high for HCC. Notice that on pre-contrast T1, there is some T1 hyperintensity that might represent blood products. So that would actually be an ancillary feature favoring HCC. On arterial phase imaging, there's no hyperenhancement that's other than in the capsule, and that the rim enhancement you cannot use for arterial phase hyperenhancement. It does have a capsule appearance. So here we have a mass that has a large size, it has a capsule, but it doesn't show arterial phase hyperenhancement. So really the highest score that we could give this is an LR4, right? Now there is an ancillary feature of restricted diffusion. We mentioned the blood products, but we can't use the ancillary features to upgrade from LR4 to LR5. So without arterial phase hyperenhancement, we can never give an LR5 score. And that's one of the reasons why using ancillary features is optional, but it's not without value if we improve our stratification of risk for HCC, because that may drive decisions about other treatments short of transplantation. It may drive decisions about biopsy and so on. Another case, chronic hep C, cirrhosis, also a history of lung cancer. Here we have a lesion that's faintly T2 hyperintense. It's really not visible on pre-contrast. There is mild arterial phase hyperenhancement. It has washout and a capsule, but it measures 1.5 centimeters in diameter, and it's a solitary lesion. So that's LR5 using LI-RADS, but it's only 1.5 centimeters. So what does that mean for management? You know, for example, would you consider ablation of this tumor? And the answer is that in general, you're not going to ablate a tumor like this, especially if the patient is being considered for transplantation. And the reason is that using OPTN, you cannot get exception points for a single HCC tumor that's less than 2 centimeters in size. Even if you biopsy it, you cannot get exception points. And if you ablate it, you sort of destroy the evidence, so to speak, and you never get exception points for that tumor, according to OPTN. It's one of the kind of paradoxical things about OPTN that we live with, but that's kind of the rule. So if the patient's not a transplant candidate or doesn't want to transplant, then ablation might be an option, or other local therapies. But this is why these cases typically go to liver tumor board, where all these issues can be kind of parsed. So size is a very important thing when we use LI-RADS, and we have to be very mindful of the implications of our measurements. First of all, size correlates with malignancy, and also with the reliability of our imaging characterizations. So for observations less than 2 centimeters, keep in mind that if it's less than 1 centimeter, it can never be an LR5, and it will never get an OPTN class for MELD exception points. If it's at least 1 centimeter in size but less than 2 centimeters, it can get an LR5 classification, meaning high probability of HCC. In OPTN, it would be a 5A, so you could only get exception points if you had at least 2 or 3 lesions with 5A classification. So that brings us to the Milan criteria. So Milan criteria, which essentially correspond to a stage 2 HCC, have been the traditional limits for when a patient is considered eligible for transplantation. And so for single tumors, they have to fall between 2 to 5 centimeters to generate exception points for HCC. If they're less than 2 centimeters, you have to sit there and wait and watch it grow until it gets to 2 centimeters. And then if it meets criteria, you can list the patient for transplant with MELD points. I will say that because ablation and some other local therapies may provide similar or identical survival rates to surgery or transplantation, this is being considered more often in patients, especially if they're not interested in transplantation. Remember that OPTN will allow biopsy as a major feature for lesions that have arterial hyperenhancement and are at least 2 centimeters in size. Now, if you have 2 to 3 observations that meet criteria for HCC, you can qualify for MELD exception points if they range in size from 1 to 3 centimeters and do not exceed those measurements. And again, in this scenario, if you have 2 or 3 nodules, you can biopsy a lesion if it's at least 1 centimeter in size to establish the diagnosis. We'll talk about downstaging later. Now, I thought it would be helpful to look at the LI-RADS table, which is on top, and I constructed a sort of a comparable OPTN table on the bottom. And I designed it to look just like the LI-RADS table by having the features aligned in the same way. And so if you look at this table, the first thing you'll notice is that if you have no arterial phase hyperenhancement, then there is no OPTN score or class. Whereas we can give a LI-RADS 3 or 4 in these patients. And then similarly, if an observation is less than 10 millimeters in diameter, then we do not assign an OPTN class, whereas we might give it a LI-RADS 3 or 4. On the other hand, if you have an observation with arterial phase hyperenhancement that's at least 2 centimeters in diameter and has at least one major feature making it a LI-RADS 5, then that will always correspond to an OPTN 5B. So it's highly congruent in this column. And then if you look at observations that are between 10 to 19 millimeters in diameter with arterial phase hyperenhancement, there is some slight differences. If there's threshold growth, then it's the same. LR5 is what's called a 5A-G in OPTN. If you have a 10 to 19 millimeter observation with arterial phase hyperenhancement and washout only, this is the one time where what we call LR5 would not get a 5A classification in OPTN. So that's kind of a quirk that still is a difference between the two. Now, OPTN does take a few other things into account. One is AFP level. And so if you have an AFP level that's as high as 1,000 or even higher, then that AFP level has to be brought down with treatment to below 500, and it has to remain below 500 nanograms per milliliter for the patient to remain on the transplant list. And similarly, using UCSF criteria, we can downstage tumors now, even in our region. So for example, if we have a single HCC tumor that is 5 to 8 centimeters in diameter, you can do local therapies to shrink the tumor, and if you can get it to 5 centimeters or smaller, then it will fall within Milan, and the patient would be then eligible for liver transplant. And they have to stay within Milan while they're on the waiting list. And similarly, now you can have 2 to 5 tumors, and the details are a little bit more complicated than this. But in general, if the combined diameter of these multiple tumors is less than or equal to 8 centimeters, you are eligible for downstaging with local regional therapies. And if you can be brought into Milan and stay within Milan, then you can get the transplant. So we talked about the importance of measurements in the 2 centimeter and less range. Also, your maximum diameters matter, because if you exceed Milan or the downstaging criteria, you may no longer be eligible for transplantation. So be mindful and accurate in your measurements. Okay, so role of biopsy. So for LR5 observations, we are usually not doing a biopsy, especially if they're a surgical or transplant candidate. Partly because you're going to get tissue from the surgical resection specimen or the explant that can be used for molecular analysis and so on for future management. But you're also avoiding the possibility of tumor seeding with a biopsy. But if you have an LRM mass, in other words, we're not confident that it's HCC, biopsy may be essential and will guide decisions about surgery or non-surgical management. If it's an LR4, again, it may be appropriate to do a biopsy once it's reviewed by the liver tumor board. As we mentioned, biopsy of a solitary tumor less than 2 centimeters, even if it turns out to be HCC, will not get you MELD points, exception points for HCC. On the other hand, if it's 2 to 5 centimeters with arterial phase hyperenhancement, but no other major features, a biopsy is allowed to establish the diagnosis and generate MELD exception points. Okay, so here's a case where we have 2 lesions, and each one is in the 1 to 3 centimeter range. And they did show arterial phase hyperenhancement. They have a capsule, they have washout, so they're LI-RADS 5. And in this case, because one of the tumors is at least 1 centimeter in size, we could biopsy this to establish the diagnosis of HCC, and we could also ablate these because this meets the criteria for OPTN 5A lesions, and since multiple could get you exception points. If you do a biopsy for HCC, please remember not to do everything you can to avoid puncturing directly into a subcapsular HCC tumor. That's going to increase the risk of not only bleeding complications, but tumor seeding. Instead, try to choose an approach where the needle goes through at least 1 or 2 centimeters of uninvolved liver. Now, I think while we have become sort of, we've been in an era where we seldom biopsy HCC, we're already noticing that we're doing more biopsies for HCC than we were even 2-3 years ago. And the reason is that molecular characterization, genetic characterization is factoring into the treatment of patients with HCC, especially the non-surgical, non-transplant patients. And so we're going to be doing more of these biopsies again in the future. So there are studies that have compared the accuracy of a LI-RADS 5 score versus an OPTN 5 score. And just in general, what these studies tend to show is that they have comparable specificity. So the positive predictive value for HCC is very comparable between the two, but the sensitivity of LI-RADS seems to be a little bit higher. And that's probably because of the scoring of lesions between 1 and 2 centimeters in diameter. So here's a patient, and honestly, I don't recall if this patient had risk factors for HCC, but let's say the patient did. So here we have a mass that is a large mass with a lobular contour. It has kind of a laminated architecture, and the enhancement is somewhat progressive as we go through the later phases, and there is some peripheral rim washout. Again, that's not a feature of HCC, but it is something we see in cholangiocarcinoma. And along with the progressive enhancement, and also notice on the T2 coronal, the tumor is growing around these vascular structures without occluding them. And that's something we see with cholangiocarcinoma sometimes, as well as upstream biliary dilatation. So this would be a LI-RADS M, LRM, or because we suspect cholangiocarcinoma. And I always thought that these intrahepatic cholangiocarcinomas look a lot like geodes that you see in the Natural History Museum because of their laminated and lobular appearance. So LRM, these observations usually turn out to be malignancy in a high proportion of cases, but they're often not HCC. The second most common malignancy in cirrhotics is cholangiocarcinoma. And then about 5% of HCC patients actually end up having a mixed HCC cholangiocarcinoma. And it's important to know that the management of these patients is different. You know, they're treated more like a cholangiocarcinoma patient. And so you're not going to get exception points based on an LRM score in LI-RADS. And most of these patients will get a biopsy. So here's a spectacular example of a mixed HCC cholangiocarcinoma. You can see that there are multiple masses with arterial phase hyperenhancement. Notice that many show definite washout and capsule, enhancing capsules. But this large anterior mass has persistent enhancement and no washout that's greater than background liver and no capsule. And on biopsy, this was a poorly differentiated carcinoma with features of both HCC and cholangiocarcinoma. If you've ever wondered why we see these mixed tumors, the current thinking seems to be that, you know, intrahepatic hepatocellular carcinomas and cholangiocarcinomas really are not arising from mature bile duct epithelium or mature hepatocytes, but rather from progenitor cells or stem cells that then become malignant and can differentiate in different directions. And that's possibly why we see these mixed types of tumors. And then here's an example of LRTIV, or tumor in vein. For you to call this needs to be a definite finding where you're sure that there's enhancing tissue going into a vein. It's important because these patients then are not generally considered surgical candidates or transplant candidates. Their risk of recurrence is too high. And so if it's a definite finding, you can call it. It's usually seen with HCC, but surprisingly often in cholangiocarcinoma and even other malignancies. So the last thing I wanted to say is that when we call findings, major observations or ancillary features using LI-RADS, we want to be definite. In other words, when we're sure that the finding is present, we can call it and use it to calculate our LI-RADS score. If the finding is equivocal or we're not sure, for example, if we're not really sure there's arterial phase hyperenhancement and yet we call it, what happens is our specificity for HCC drops, and then LI-RADS is not as accurate. So as a general rule, all of these findings need to be pretty convincing for us to call it. Otherwise, we're going to be less accurate. So with that, I will stop and certainly happy to take any questions or hear any discussion.
Thanks, Paul, for that wonderful overview. So we'll open it up to questions if the group has any comments, questions.
Hey, Paul, I have a question. I know you didn't touch on this, but in patients that undergo treatment for HCC, LI-RADS has a pretty specific algorithm, but what I often struggle with is kind of the signal characteristics we see around the ablation zones, right? Looking at the ablation images and thinking there's probably an adequate margin there of coverage, meaning the ablation zone extends beyond, but kind of differentiating that kind of periablational zone signal versus kind of how do you know it's not, trying to get away from the LRTR equivocal because I'm not exactly sure what that signal is doing.
Yeah, it can be challenging. And part of the problem is that we don't always see the tumor ghost in the ablation zone. And so we often see a non-enhancing ablation zone and the tumor is obscured in the ablation zone. So it makes it a little bit hard to know what the margin really was. Sometimes on MR, we do see the ghost. And what I would say is look at all the sequences to see if you can identify the ghost of the tumor. That'll help you. Otherwise, we just have to decide if it's a fairly uniform rim of enhancement or circumferential, it's probably benign. If it looks like shunting or sort of shows transient enhancement in the arterial phase and then disappears, it's probably shunting. If you see nodular enhancement, then it's more worrisome. Or if it's new mass-like appearance or nodularity, of course, it's suspicious. But I know what you're describing are sort of the problematic cases, and there are cases where it's more challenging.
I have a question for you, Dr. Shyn. Thanks very much for the talk. For the positive predictive value of LR tumor in vein, I thought that I was a little surprised that it was only 54%. Is the other group including bland thrombus, or is it also partially the combined HCC cholangios, or why is that not more predictive?
Yeah, so I think it's tumor in vein is seen with cholangiocarcinoma also, and even other malignancies. So I was a little surprised at that too. I would have thought maybe 2/3 would be HCC, and maybe it's center. It depends on what center you're at, but for whatever reason, that was the statistic that was generated from at least one study. But the bottom line is that if it's enhancing tissue going into the vein, it's almost always malignant, and it may be HCC, but it could be a different malignancy too.
Thanks.
So Paul, I have a logistical question. In our practice, patients that come from transplant, they clearly are asking us to give an OPTN classification, and there we could, sort of transpose to LI-RADS category very easily. But for the vast majority of patients where sometimes there is no clear history of cirrhosis, or they have had something seen on ultrasound, and so how do you guys use your LI-RADS template in terms of deciding when to apply it?
So usually, so if there's a history of cirrhosis, like a previous biopsy, then it's easy. If there's a history of chronic hepatitis B, then it's easy. If the imaging looks like, it's cirrhosis, we just apply LI-RADS and we say, that the liver looks cirrhotic. But there are a small fraction of cases where we just don't know. And in those cases, we sometimes will say, if the patient has cirrhosis, then this would be a LI-RADS 5, And so there is a small fraction of cases where we kind of parse it in that way. So, somehow we have to decide whether or not the patient really is at high risk for HCC.
Thank you. Any other questions, comments? If not, thank you, Paul, for your time. And again, I'm sure this is one of many. We probably will need, more primers, and in terms of us embarking on this journey to transpose from, OPTN to LI-RADS category. But thank you again for taking the time, and thanks, Alan, for facilitating this.
My pleasure. Thank you.
Thank you.